It is my pleasure to introduce Dr. Kathrine Twombley, the Division Director for Pediatric Nephrology and the Medical Director for Pediatric Kidney Transplantation and Dialysis at the Medical University of South Carolina, where she also serves as a professor of pediatrics. A central focus of Dr. Twombley's research is antibody-mediated rejection, AMR, and its long-term effects, such as hypertension, donor-specific antibody development, and chronic kidney disease. Just a second. She's currently the primary investigator on a multi-center grant with the Midwest Pediatric Nephrology Consortium, where they're investigating the complications of kidney transplantation. So feel free to get started whenever you're ready, Dr. Twombley. Thank you.
Thank you. Can y'all see my screen okay?
Yes.
Perfect. So for anybody who hasn't been to Charleston, South Carolina, this is just a couple of the beautiful pictures here around the city. I do have some grant funding with a company called Konica, who I am part of the post-FDA approval study with this group on LDL-Apheresis, and I will be talking about this treatment in this talk. So just know that I do have research funding with them. And then I'm on an advisory board on the neurocognitive effects of cystinosis with Horizon. So nephrotic syndrome, what is normal and what is abnormal, right? So I know the majority of y'all know this, but I was just going to do a little brief because it helps go through what's going on later. So the kidneys usually work early in nephrotic syndrome, and the problem is they let go of things that they shouldn't let go of. So what kind of things are they letting go of? Well, antibodies for one, depending on the type of nephrotic syndrome, and so that puts you at high risk of infections. Albumin, which causes swelling, high lipids, low blood volume, dehydration, things like that. And then anti-clotting factors, which keep you from clotting. So therefore you end up with blood clots, partially in combination with the low albumin. So this is a picture. So if you're looking at the screen, I'm hoping your left is the same as my left. So, or you can see my cursor. You can see these little foot process from the podocytes here, and this is an electron microscopy. And then you see over here, you don't see those little foot processes anymore. They've kind of all shriveled up in here, and they're no longer where they should be. The primary causes of nephrotic syndrome, the primary nephrotic syndrome, 90% of the cases are between 1 to 10 years of age. Most of the cases start off as minimal change. Every now and then we'll get a focal segmental glomerular sclerosis on the initial diagnosis. Membranous, interesting fact, I've probably seen one primary membranous in 15 years in a child, and we've had 2 this week. So something in the air. And then membranoproliferative glomerular nephritis, and that's the top 4 most common. Secondary would be things like lupus, IgA nephropathy, or Alport syndrome. So when you look at nephrotic syndrome in kids and adults, it's 2 completely different diseases. So in children, 76% of the cases are, or at least start off as minimal change, whereas in adults, less than 60, it's only 20%, and more than 60, it's only 20%. The most common, second most common in kids would be FSGS, whereas in adults, less than 60 years old, it only makes up about 15%. And then membranous is by far the most common diagnosis in adults, but it's very rare in children. So the presentation, it classically, like I said, classically presents between 1 to 10 years of age. Swelling is typically the first thing we see. That I would guess more than 50% of the children we get for nephrotic syndrome have been either to the pediatrician or to the ER with eye swelling and been treated for allergies before they make it to us. Some of them have even been given some short course of steroids for allergies, and really kind of muddles our diagnosis when that happens. It's typically gravity dependent, so it settles in places. And you can see here how that mild edema might easily be missed if people aren't paying attention to the real definition of what you should see, or you can imagine if it is an obese child, that mild edema would be very easily missed. And it's usually not picked up to its at least the moderate or severe on the first time. So treatment. In minimal change disease, the most common treatment is steroids. More than 90% of kids who are diagnosed with minimal change will respond to steroids. Therefore, we typically empirically treat with steroids between 1 to 10 years of age. Some literature goes up to 12 years. More and more people are starting to treat all pediatrics, regardless of the age, without a biopsy with steroids first, because their thought is, well, if they respond, then, you know, even if it shows FSGS or membranous or MPGN, you're probably still going to try a trial of steroids. So a lot of people are starting to, or let me not say that, some people are starting to wait, but the standard of care is still to biopsy anyone over 10 years of age. We typically start with prednisone 2 milligrams per kilo per day for 6 weeks with a maximum dose of 60 milligrams, and then taper 1.5 milligrams per kilo on alternate days for 6 weeks with a max dose of 40 milligrams. And like I said, 80 to 90% will respond to steroids. 30% of responders will not relapse. My population in the South, I can count on one hand how many kids have not relapsed. 10 to 20% relapse less than 4 times a year. Frequently relapsing is defined as relapsing more than 4 times a year, and that happens in about 30 to 40%. Steroid dependent are children that once you start tapering their steroids down, they relapse. And then there's steroid resistant who do not respond at all. In the South, we tend to have more frequently relapsers and steroid resistant than we do steroid dependent. Up north, they tend to have more steroid dependent. We're not really sure why that is or what the genetics behind that are yet, but that is something we talk about at society meetings all the time. Patients with frequently relapsing steroid dependent or steroid resistant disease often go through a gamut of other medications. Unfortunately, we don't have a crystal ball that tells us which children will respond to which diseases. That is an area, or which diseases will respond to which medications. And every disease is different in every child. So, you know, some people start with the cyclosporin or tacrolimus. Some people start with MMF. It just kind of depends on their experience in that area. Cyclophosphamide is usually reserved for steroid dependent, although there are some protocols for steroid resistant for cyclophosphamide. Rituxan or Rituxan derivatives have become incredibly popular and have had good success with them. And then finally, LDL-Apheresis is one of the newer treatments that has come about. So the question always comes, the chicken or the egg, you know, and it's not protein versus hyperlipidemia as far as which one comes first, but it's, you know, which one does more damage. Historically, protein was thought to be a sign of damage. So whenever someone had protein in their urine, you always were like, oh, we got to get the protein out because that's a sign that their disease is active. Now we know that protein itself can actually cause damage to the kidney. So it's not just about removing it because it's a sign of the disease. It can also be a problem in and of itself. So immunosuppression, so the cure, is it worse than the disease? So, you know, when you look through here, steroids, you know, there's a risk of diabetes, and with calcium urine inhibitors. Calcium urine inhibitors also cause tremors, which are when your hand shakes when you're at rest. All of these can lead to high blood pressure. If your blood pressure gets too high, that can lead to seizures. Alopecia, we've had a handful of kids who have gotten alopecia from tacrolimus, not a lot, but it does happen. The steroids in particular cause weight gain. And over time, all of these medicines used for a long period of time can cause chronic kidney disease. So the medicines do not come without risk themselves. So you go, now what? Where does that leave us? Well, if you look at this is the most common causes of patients on dialysis. The most common diagnosis, the first one would be either hypoplastic or dysplastic kidneys. Second would be obstructive uropathy. Things that fall in that category are things like neurogenic bladder or urinary ureteropelvic junction obstruction, things like that, anything that causes a blockage in the system. Reflux nephropathy would be next, so that's urine going in the wrong direction. And then FSGS is the fourth most common cause, and those make up about 50% of the kids that end up going into end-stage renal disease. So where does minimal change fit in this, right? We said minimal change was the most common cause. Well, so here's a kidney. So when you look at this little circle, okay, all these little circles represent something called this is our focal area. So when we talk about focal segmental glomerular sclerosis, focal means that within the kidney, these little circles are focally affected by sclerosis, okay? So if I put my needle, when I do a biopsy, into this kidney, and this kind of shows you what we go through when we're doing a biopsy, if I put my needle here, my diagnosis is minimal change disease because I didn't hit that focal area, okay? But the longer and longer this disease progresses and doesn't go into remission or relapses frequently, you develop more and more of these focal things. So when you biopsy the child a second time, you end up getting FSGS. And that's why, to me, when I'm talking with colleagues and we talk about children having FSGS or focal segmental, that is a pathology diagnosis, and to me doesn't mean near as much as the clinical diagnosis. Are they steroid resistant? Because if they're minimal change disease on biopsy and steroid resistant, to me, that is a much worse prognosis than a child who has FSGS who is steroid sensitive. So you have to kind of take with a grain of salt when, you know, historically people said, oh, everybody grows out of minimal change disease. Well, they don't always grow out of minimal change disease. Minimal change disease is probably masked by FSGS in a lot of the cases. So nutrition. So nutrition is important, particularly during the infantile phases, because the rate of growth is higher than at any other time postnatally and is less dependent on growth hormone than in other phases. The rate of growth gradually increases from more than 25% per year at birth to an average of 18 centimeters per year at 1 year of age. So they grow an incredible amount in the beginning. And I know all of you parents know this. And half of your adult height is usually reached by the age of 2 years. So at that point, irrecoverable loss of growth potential can occur during this phase. So when you look at CKD, you have renal disease, which, you know, you're losing some of your residual renal function. You have all these toxins in there. It's affecting all of your other hormones in your body. You're not eating well because you don't feel good. We're limiting your vitamins because your kidney can't handle it. And then you get all these comorbidities in there. CKD in and of itself is an inflammatory condition. So that just piles on with everything else. Plus, when kids are on dialysis, or in later stages of CKD, they don't have as good physical activity. We're putting them on a bunch of drugs that promote fat, fat deposition and muscle wasting. There's social factors involved. So all of this stuff really leads to poor nutrition during all this. So kids who end up going into renal failure really do have effects on growth. So younger subjects have the highest height deficits at the time of transplant, mostly because what I just told you is you get the majority, half of your adult height by 2 years of age. So the kids that really saw the biggest deficits were those who were in chronic kidney disease and transplanted very young. So they often need G-tubes because a lot of kids who have CKD have oral aversions. We're not really sure why. It's, we always talk about uremic toxins, and BUN is the uremic toxin that we can measure, but there's a lot of other ones in there also. And the thought process behind this is that something to do with one of those uremic toxins really causes altered taste sensation and really makes kids not really want to eat afterwards. There's also developmental issues with chronic kidney disease. So a lot of kids have reduced environmental exposure and exploration for infants and toddlers, especially when they have PD catheters, and parents, rightfully so, are like, don't play in the mud, don't get it dirty, don't want your kids around other sick kids. So there's a lot of things that fall into that. Plus, they spend a lot of time in the hospital or clinic appointments. They could have lengthy treatments at night with PD, reduced physical stamina, and really have a restricted social system at that point. Other developmental issues are, fears and understanding of medical procedures. Kids understand a lot more than we give them credit for a lot of times. So it can be very taxing on them to know they have a doctor's appointment if they're thinking they're going to have shots or blood drawn or something like that. There's parent and adolescent relations. There's really, we kind of see two kinds of parents. We have, and please don't think I mean this disrespectfully, but we have the group of parents who we call the hovering parents, who really do everything for the child, which we love. Is fantastic. We know the kids are getting their medicine on time. Everything's great. But then when the child goes to college, everything falls apart because the parents been doing them the whole time. And the children really become dependent on the parents. There's, privacy issues because, when a 17-year-old is in the room with mom talking to us, they don't want to talk about some things that they would normally probably talk to in a pediatric setting. And the children really feel like this lack of perceived control. And I've heard more times than I can count adolescents say, I just want to be normal. And they quit taking their meds and all of a sudden they're in the hospital. Why'd you quit taking the meds? I just want to be normal. And they just don't get the concept of the meds are keeping you normal. So you've got to take them to not be here in the hospital. So there's all kinds of things that are going on here. And a lot of work is being done with this right now with the SONG initiative. There are neurocognitive effects of end-stage renal disease. Children less than 5 years of age tend to have significant cognitive delays when they're diagnosed with end-stage renal disease. Children more than 5, there's no difference in the overall IQ, but there are very specific differences, some comprehension problems. We've seen lots of learning disabilities that come out when children more than 5 are diagnosed with end-stage renal disease for any significant amount of time. Patients with earlier onset and longer duration of renal failure performed at lower levels than the healthy peers, even after transplant. So it's incredibly important not to spend a lot of time on dialysis if possible, because a lot of this can be prevented or at least decreased, the effect of it if children are transplanted earlier. There's also psychosocial effects. So dialysis patients tend to have more severe difficulties than patients who are transplanted preemptively. There's a lot of fatigue that goes along with it. There's school absenteeism because they're in clinic or they're in the hospital. A lot of health concerns from the child and physical side effects from anybody who's had a child on steroids or cyclosporin knows the effects. Some kids have adjustment difficulties. And then a lot of kids who aren't treated with growth hormone at the right time have short stature and cushingoid facial features. So all of this is really difficult on the child. So obviously we want to get the kids to transplant as soon as possible. So this is a controversial topic, but I'm going to talk about it and I'm going to tell you my opinions on it. And you don't have to agree with my opinions. Some of it is evidence-based. Some of it is just from my years of experience. And I'm gonna go from there. So why did we even start doing nephrectomy? So in 1968 or 1978, this was published. And up until 1971, all patients who were nephrotic, actually all patients, I take that back, it's not just nephrotic, all patients who were going to have a transplant had their kidneys taken out, okay? Because at that time, they didn't really know if it was good or bad to do. So they just took them out thinking, they're not working, why leave them in? Problem with this is, and here's some of the reasons they did it. But so they said, okay, so number one, it'll really tell us what the original disease was, and that might help us. So it's going to eliminate a source of infection. It's going to avoid possible reoccurrence of original disease, control hypertension, eliminate the risk of hematuria, abdominal pain, stone formation, infections in large cystic kidneys, facilitate more accurate monitoring of post-transplant urine volume, eliminate risk of unrecognized malignancy, and to take the transplant's distal ureter that would be available if needed during the transplant. So this was the thought process in the beginning, okay? Problem with this was they did a retrospective review of this practice, and a lot of people received blood transfusions, and it averaged 1.9 units per patient. So it's not a benign procedure to take someone's kidneys out. The mortality rate was as high as 3.6%, because if you think about it, I'm betting the majority of this mortality was probably in very young patients and nephrotic patients, because if you're nephrotic and you're don't have the antibodies and different anti-infective properties in your body that you're losing from being nephrotic, that you might get infected after a big surgery like this. And back in this time, they were all done by open. They were not laparoscopic back in those days either. So it was a huge open kind of stem to sternum type procedure. 1.4% had nephrectomy only, but another 5% had nephrectomy and some other kind of procedure done at the same time. So it wasn't just nephrectomy in a lot of the patients. And you can see what the majority of the complications were here. So at that time, they said, okay, maybe we don't need to do it on everybody. So I'm going to tell you what my practice is at my center. So, and why, and because of this, we've come up with very strict guidelines for why we take kidneys out and why we don't. And more often than not, we leave them in. Nephrotic syndrome is one of the caveats to that. So number one, severe resistant hypertension. So if you're on 3 or more antihypertensive medications pre-transplant, we will take your kidneys out, because more than likely the steroids and the calcium inhibitors, both known to cause hypertension, will cause worse hypertension and more complications. So if we can't control your blood pressure with 1 or 2 medications pre, we will take it out post. Polyuria. So it's not an absolute indication, and the literature on this is changing. So there's 2 schools of thoughts on this. If you pee a lot pre-transplant, you're definitely going to pee a lot post-transplant, because the post-transplanted kidney can't regulate urine output well for several months. And so kids might pee 2 or 3 liters a day. If you're already peeing 2 or 3 liters a day, now you've got 5 liters of urine output a day, and children just can't keep up with that intake with that. So, and if you get dehydrated, you run the risk of clotting your graft, and that's just very bad. Some school of thought is that once the new kidney is in, that old kidney will stop making so much urine. I have yet to see that happen in our children, and the kids that we've ended up not taking the kidneys out for polyuria, we've had to do some types of intervention around a month or 2 later, either embolization of the kidney or just clearly taking the kidney out, because the children were at risk of losing the graft because they just couldn't keep up with the increased input. So we do most of ours laparoscopically. So the risk of all of those things happening before are incredibly small. And these are 2 of the recent kids that we ended up taking back to the OR. Pre-transplant, patient number 1 had a little over 3,000 mLs of urine a day, and after it went up to 8 liters. And then child number 2 had 2 liters a day with no proteinuria, but had 7 to 8 liters per day afterwards. And both of these patients, the nephrectomies were done at around 25 and 27 days post-transplant laparoscopically. And so that therefore they didn't have to have a big surgery to have them taken out. But they spent the first month in the hospital after transplant because we couldn't ever keep their intake high enough to meet what was going on. So it really prolonged their time in the hospital. Proteinuria. So the expert group on renal transplantation in 2002, based on the best practice guidelines for transplantation, said long-term management of the transplant recipient, they recommend nephrectomies for heavy proteinuria. I do too, for multiple reasons. I've had families come to me and they'll say, oh, so-and-so didn't have their kidneys taken out at another center and they just did fine. And yeah, they probably got lucky. It's not that every kid who doesn't will have a complication, but the risks of complications are so much higher if you don't, that it's just not something I'm willing to take a risk on. So when your protein is low, you need protein to heal wounds. So number 1, your wound healing isn't good if your protein's well. And so kids that don't have nephrectomies, who are massively nephrotic, end up usually with wound dehiscence and these nasty scars and When they're teenage girls, they get mad that their scar looks so bad. And I've had kids have to go back to the OR to have that scar revised because they were so nephrotic at the time. They get a lot of clotting issues, especially if they reoccur and we end up having to put a line to do some kind of treatment in. 9 times out of 10, that line will clot if they're actively nephrotic. And then we've also, over the years, I've had a couple of kids clot kidneys off pretty close after transplant because they were so nephrotic. So these are just risks I'm not willing to take. I know some centers will and some people will, but I would feel terrible if a kid lost a kidney because of something that I could have predicted that would happen. So if they're still nephrotic without a genetic diagnosis, we do bilateral nephrectomies. And so you have to be nephrotic range proteinuria for us to do this. So more than 40 milligrams per meter square per hour on a 24-hour urine, or a ratio of more than 2 on a spot check. We also measure protein C, S, and antithrombin 3 levels prior to nephrectomies, and then we follow those. And once those levels are, and those are your clotting, your anti-clotting factors. So once those are normal, then we know it's safe to transplant you. Also large kidneys. When you look at this, this is a patient that has autosomal dominant polycystic kidney disease. And can you imagine where I would put a new kidney in here if my surgeon took this child to the OR? There's just nowhere to put them. So in things like this, we usually have to take them out significantly sooner than transplant because these kids don't grow. Because if you see right up, you see this little nubbin right here on top of this kidney, that's the stomach. So there's no room for food in there, and the kids just can't get enough nutrition. A lot of times we'll take out one kidney to let the stomach expand and so they can get nutrition. And then at the time of transplant, we'll take the other kidney out unless they're having a bunch of infections or bleeds or something like that. And like I said, not just for the proteinuria, but recurrence of original disease. So I don't feel that taking the kidneys out prevents the reoccurrence. I don't think it prevents it or causes it, but it sure does make everything a lot harder afterwards if the native kidneys are there, because I can't tell when someone's going into remission and when they're not, and children will end up getting exposed to a lot more immunosuppression than they actually needed. So let's talk about the different diseases and what their rates of reoccurrence are. So with FSGS, there's about 30 to 40% reoccurrence in children, 20 to 50% in adults. And this is overall in South Carolina. My risk of reoccurrence here is probably closer to 60% just because of whatever genetic milieu we have here. Remember I told you we have a lot more frequently relapsing patients and a lot more steroid resistant patients. And those are the patients that I typically, I can almost predict who's going to reoccur and who's not. Typically, it's apparently immediately post-transplant, usually within 12 hours, we know whether they've reoccurred or not. The mean time of onset is about 14 days. And there's about a 50% risk of allograft loss with recurrent FSGS in the literature. You know, I don't see that. I've yet to lose a graft from recurrent FSGS. And I don't know that I'm doing anything different than anybody else. Maybe I am. But I have yet to lose a graft from recurrent FSGS since I've been in practice. Now, the ones I saw clot off from being nephrotic who lost their grafts were when I was in fellowship. And that's one of the reasons I don't leave kidneys in nephrotic patients. So, but with my practice, I have never lost a graft from recurrence. Now, I've had to treat kids for a long, long time to get them in remission, but I've typically been able to get them in remission. So some centers have looked at preemptive rituximab or plasmapheresis. This has not been shown to prevent reoccurrence, and it has not been shown to decrease the significance of the reoccurrence. They still reoccur, and they still have to be treated the same. Risk factors are rapid progression to end-stage renal disease, less than 3 years. Presence of mesangial hypercellularity on the biopsy, age of onset more than 6 years of age, previous reoccurrence in a transplant. If you reoccur in the first one, it's anywhere from 85 to 100% chance you'll reoccur in the second one. Caucasian race, And adolescent recipients have poor graft survival when they reoccur for a multitude of reasons. One of the big hypothesized reasons is compliance, but I think it has way more to do to that. And I think there's some hormones that play into how the medications work around that time that also have some say-so in what happens. So your treatment options, historically, plasmapheresis has been the standard of care. LDL-Apheresis is now the standard of care in my center. I've had children who I've done plasmapheresis on and they have not responded, but they have responded to LDL-Apheresis. So it is an option for kids that don't respond. Rituximab is also an option. High dose calcineurin inhibitors, and then ACE and ARB therapy. So, people always go, okay, what do you do? Well, I'm gonna tell you my practice, but that doesn't mean that's the know all be all. And this is just what I'm comfortable with and what works in my patient population. Is if they reoccur, I immediately give them a dose of rituximab, and then I start the LDL-Apheresis treatments. LDL-Apheresis is done twice a week for 3 weeks, and then weekly for 6 weeks. And patients do not respond typically until at least the 6th or 7th treatment, sometimes longer. But I take that back. Typically, yes, my patient I started on treatment about a month ago after transplant, she went into remission incredibly quickly within 2 weeks. So she's the quickest one I've ever had respond. I don't like to do high dose calcineurin inhibitors because it is tough on the graft, and I'm not convinced that the long-term nephrosclerosis that can happen with high dose calcineurin inhibitors, I'm not convinced that it doesn't decrease the life of the graft. So I really do not do that. And starting about a month out, I do ACE and ARB therapy as well. So if you look at this on the left, so on the right, this is a regular plasmapheresis machine. So you can see there's some red lines here and some yellow lines here. So the red is the blood is coming from the patient. It's going down into this tube here. And inside this machine is a centrifuge that spins that blood, separates the plasma, and it takes the plasma and puts it in this bag over here. And so this is patient plasma. And then it gives the patient either fresh plasma or albumin. So it does require a transfusion, but it removes the evil humors, whatever that is, supposedly for patients. LDL-Apheresis, on the other hand, is a little different concept. So this is what the machine looks like. But rather than it having a centrifuge, the blood comes in through a filter. The first filter separates the plasma out and sends the plasma to another filter, which has a charge on it and removes LDL particles only, so LDL-A particles only, and which includes lipids. So this treatment was originally done for hypercholesterolemia, and what they found through all their research is that other diseases that have high lipids actually do well for this. So the thought process kind of behind it is the hyperlipidemia. You remember I was talking about the chicken and egg earlier with the proteinuria. Well, the same things can go with the hyperlipidemia also. We know that some drugs that are protein bound, their effectiveness is significantly reduced when someone has high lipids. And so if you can get the lipids down, you can see some of these drugs work better. And so this is the thought process behind that. The original papers, or the original paper that described this was Hattori et al. In 2003. And they described patients less than 21 years of age. And the post-FDA approval study is what I'm taking part in. And so it's already an FDA-approved treatment, but anytime the FDA approves a treatment or a drug, they always collect data post-FDA. So any patient I treat with I submit data to the FDA so they can keep track of safety and efficacy and side effects and all that kind of stuff. It used to be more than 21 kilos. We're now down to 18 kilos on what we can do safely. And this is kind of what the course looks like, except we don't use prednisone there. Now I want to go into the effective donor type, because there's a lot of literature out there saying don't use living donors, it's incredibly controversial, or it was somewhat controversial initially. It's getting clearer now. So there are similar rates of graft loss in living related donors and deceased donors. If the only time we say don't use a living donor is if the graft, if you reoccur in a first kidney, we would not take a second living donor for the second transplant, because if there's an 85 to 100% chance of reoccurrence, and if they lost the graft on the first one, you don't want to do harm to the donor at that point. So, there's many reasons why living donors are better, mostly because everybody says, oh, well, we'll do the deceased donor here. And if they, and then when they need a second kidney, I'll donate. Well, I'm a mom, I have a 14-year-old. And if that first kidney lasted her 15 years, what is my health going to be 15 years from now? So I'm a healthy, 40-something-year-old. And I really, when I'm closer to 60, am I going to be a suitable candidate for my child? So we usually say don't bank on a living donor for the second one, because a lot can change during that time. And you don't know if they'll be okay to donate at that point. So, but there really is no difference in reoccurrence with living and deceased. So we don't go down that route. And so IgA, there's a high risk of reoccurrence from here. Most of the reoccurrences were found on protocol biopsies, so they weren't clinically significant. From clinical symptoms, only about 13 to 50% reoccurrence rate, and the 50 is not, I think, is accurate. There's a higher rate of reoccurrence in living donors, but there's no increased risk of graft loss compared to deceased donors. But there is a risk of reoccurrence in subsequent transplant if the first one failed from reoccurrence. And it says anywhere from 20 to 100%. The literature is just very wide on that. We do not take kidneys from someone we know has IgA, but we will take living donors in patients who have IgA if neither of the parents have hematuria. So there's really no effective therapy or prevention for recurrent IgA. We do know you do not want to convert to sirolimus as it worsens the reoccurrence. There's no studies on fish oil post-transplant. We do use ACE and ARBs for protein control. And if they've lost their first graft from recurrence, once again, we don't use a living donor for the second one. Membranoproliferative glomerulonephritis is often secondary, but if you treat the underlying condition, it usually reduces the risk of reoccurrence. And that's usually more with adults who have like hepatitis and things like that cause MPGN. It's important to differentiate between recurrent and de novo disease. It is not uncommon for kids or adults after transplant to develop de novo, meaning new MPGN, regardless of what your primary diagnosis was. And it's mostly because this is an autoimmune type process, and so you can stimulate that system in a lot of different ways. But there's no real effective therapy when this occurs de novo or reoccurs. And then this is, hold on a second. I have all of a sudden lost my ability to see my screens.
Oh no. You're gonna try to reshare your slides?
Can you see it now?
Yes, we can.
Perfect. Okay.
Okay.
So, sorry, I don't know what happened. It just kind of blanked out there.
No
so
worries.
MPGN1, so 20 to 50% reoccurrence. It presents with proteinuria and deterioration of renal function. We do know that there's certain HLA types of people that have an increased risk. Living related donor does tend to be an increased risk. We think it's those who have similar HLAs, but we do know the second, if you lose it from the first, it's a high reoccurrence in the second one. So fortunately, we don't see as much MPGN, but if if we have a young donor, we will take a living donor from that if they don't have HLA-B8 also, or DR3. NPGN2 has a much worse recurrence rates of around 80 to 100%. And it's not an immediate reoccurrence. It usually occurs in the first year post-transplant, but it's usually a slow and progressive decline. Graft loss occurs in about 15 to 30%. And there's really no correlation between complement levels and recurrent risk with this particular disease. So C3GN, we don't know a lot about C3GN. The data I'm getting ready to give you is all in adults. We do diagnose children with C3GN, but they usually don't progress to end-stage renal disease until they're adults. Therefore, most of the transplant data we have on reoccurrence comes from the adult literature. The recurrence rates in one study was described as substantially high, 60 to 85%. So similar to your NPGN. There was a study called Prospero, which was a meta-analysis, and they looked at 12 studies with 7 cohort studies and 5 case series consisting of 122 kidney transplant patients with C3GN. They looked at C3 and dense deposits, since those tend to be the closest. The allograft loss in C3GN kidney transplant patients was 22%. So they didn't tell us what they did is they looked at the treatments once they reoccurred and said, what is the risk of graft loss with it? So the graft loss with kidney transplant patients treated with eculizumab was only 22%, whereas 50% graft loss after pheresis and 70% after rituximab. Those who had no treatment had a 40% graft loss. And I was like, why would some people get no treatment? And it's not that they weren't treated because the doctor just said, why treat? It was they weren't treated because the majority of them, the doctors didn't feel that the reoccurrence was significant. They thought that it was a very mild case and that everything would be okay. And obviously they were wrong. So I have yet to have a C3GN reoccurrence, but if I did, based on the literature, I would treat with eculizumab. And so I have no idea what is going on again. I'm so sorry. All right, lupus nephritis, histologic occurrence up to 30% of the time. Clinical reoccurrence is only found in about 2 to 9%. What's important here is improved outcomes if transplant is delayed until patients are inactive for at least 6 to 9 months. My center says you need to be in remission for 6 months prior to transplant, but graft loss is incredibly uncommon. I have a textbook coming out that I just edited that we had a whole chapter on lupus nephritis, and the literature about graft loss is really impressive in that if you biopsy these patients, you'll see it in about 30% of patients, but other than that, you really don't see clinically. And then membranous nephropathy. Even post-transplant, you have to screen for secondary causes like viral infections, malignancies, things like that. It's 10 to 30% reoccurrence in what we call primary or idiopathic membranous nephropathy. It's important, once again, you can get new membranous nephropathy after transplant. And this is for anybody on here who's has a child, or you or yourself is in transplant, you might have heard of chronic transplant glomerulopathy. And one of the signs of that is really membranous nephropathy. The mean onset of time is 10 months. De novo disease or new disease occurs much, much later. And there's no risk factors have been identified, and there's really no effective treatments for it. And I think that is the end of my slides. So if anybody has any questions, I am more than happy to take questions, but I'm gonna quit sharing here.
Absolutely. If you have any questions, feel free to put them in the chat. I do have one question for you, Dr. Twombley. What are the odds that a child will recur during their second transplant if they have recurred after the first but have been in remission for years?
It's the same applies. So it depends on the disease. So whatever disease percentages I just gave you, FSGS tends, if you reoccur in the first one, they do tend to reoccur in the second one. But one thing I didn't say that I really want to hit here is pre-transplant nephrotic syndrome is a totally different beast than post-transplant nephrotic syndrome. Okay, so you were talking about a brand new kidney with no predetermined risk factors, no exposure to immunosuppression. This is a brand new slate that we are hitting hard in the beginning with multiple immunosuppression just from the transplant perspective in and of itself, but it is much easier to treat a reoccurrence than primary. So just because someone reoccurs after doesn't mean it's a bad reoccurrence. It just means we have to go after it. And it's a lot of different things, but it's the same risk of reoccurrence regardless of whether they went into remission.